Kia ora koutou, ko Miriam Nakatsuji aho. I am a GP in Clendon in South Auckland, and I also teach into various parts of the medical program here. I also work with Dr. Martire Harwood, who's a GP in Papakura, and she was unable to make it today, but what I'm presenting is really our joined experience of both of us working in primary care in South Auckland. So I'm just going to have a look at our context about what it's like in our environments and some of the risk factors in South Auckland that are contributing. Some of our own challenges in diagnosis and treatment that we're seeing every day in primary care, and thinking about looking at scabies again through an equity lens and our role as GPs in advocacy for our patients. So this top picture is where I work at Clendon Family Health Centre, and the bottom one is Martire Harwood's clinic at Papakura Marae Health Clinic. So in the Papakura clinic, 90% Māori enrolled population. In Clendon, we would have 1/3 Māori, 1/3 Pacifica. And in both of our clinics, the majority of our enrolled populations would be living in quintile 5, probably around 3/4 of our populations. Definitely every day I do a clinic, I see scabies. So the last clinical day was Wednesday, and I saw 2 patients with scabies on Wednesday. One was a child, one was an adult. Actually, both of them thought they had measles, and that's why they'd come, but I was able to tell them it's not measles, it's definitely scabies. And sometimes we take it home, and just like Simon, we've had scabies at our house too, and it's always me bringing it home to the whānau. It's not the kids getting it first, it's always me taking it back from clinic. And I remember the last time I picked it up from a patient was when a parent brought in their very cute 6-month-old baby, and the baby wrapped their hands around my fingers, and I admired them for a while, and then, so we've come with a rash, and that was a few days later, it had spread to me. So I now keep some permethrin permanently at home in the bathroom cupboard so that I'm able to get onto it straight away as soon as I get the first sign, hopefully before I pass it to the children. So in South Auckland, in counties Manukau, 1 in 2 live in the most socioeconomically deprived areas. It's also a very young population, and we've heard about how scabies is affecting the younger population in this community. We feel, when I've talked about this with Martire, we feel that it's also an issue with mobility of these communities. So people are sometimes in transient accommodation, they're moving between homes. Some people live half the week in this home and go somewhere else for the weekends. Relatives come to stay for weekends and then leave, so there's a lot of movement, and so that can really affect the ability to control when you're trying to treat many people at once. In terms of the history, there might be some kind of trigger. One of the patients I saw on Wednesday had just come back from up north where someone one of her relatives had been diagnosed with scabies. I understand from the reading that I've done that this, in terms of the time lag between exposure and developing symptoms, it can depend on whether it's your first episode or your subsequent episodes. And so there can be quite a time delay between if it's a first episode of being exposed, it could be several weeks before the patient will start itching, whereas in subsequent episodes it can happen a lot quicker. Someone could correct me if I'm wrong, but that's from what I've read. You'll often have someone who has a contact who's itching, but not always, but that's a typical thing in your history. We've talked about how people describe an intense itch most of the time. They often say that it's worse with heat and it's worse at night, and it does interfere with their sleep. It's often another red flag if you've got someone who's had a past history of scabies because of the recurrence and because of the fact that there are other relatives perhaps bringing it back to them. And in general practice, I would definitely be guilty of not classifying this on the classifications list a lot of the time, just forgetting to do that. So rather than looking under classifications for scabies, it's actually quite useful just to look at the medications that have been prescribed and then seeing if permethrin is on the list. An important part of history is to find out how many people are at home. It's often, an eye-opening thing when you ask someone that, and there are a lot of our families who are living with a lot of people in the same house, and that really makes it hard to treat. And sometimes when the diagnosis is unclear, I just have this almost reluctance to diagnose it because I know the hassle it's going to cause them to treat the whole whānau at home. In terms of examination, it's so variable, and there are many times when I'm just sure this is scabies and I can say it very definitely and quite confidently. There are other times when I say, well, it could be this, it could be that, and so there's a huge variety in terms of the lesions that they can look like. Typically the red little papules in the typical sites, especially around the wrists, the fingers, the feet, often around the tummy, the groin, so that's kind of the typical sites and the typical lesions. But sometimes they can be more like blisters, sometimes they can be crusted with secondary infection, sometimes they can be more like big papules that you would think look a bit more like flea bites or mosquito bites, but they're actually scabies too, so there can be a lot of variety. And in terms of that, actually, the burrows, on Wednesday, one of those two patients did have a typical burrow right in their wrist, but it's very rare that I would see that, and it's not something that I would rely on at all. Although when I looked up DermNet by the dermatologist, this is what they're going to say, look for burrows. Well, it's a rare thing that I would see in the patients that I see with scabies. Simon has already talked about this study, so where a dermatologist, GP and nurse went into an early childhood centre. Dermatologist found no scabies, the GP found 9, the nurse found 6, and then in terms of the people who fit the criteria for suspected scabies on this IACS criteria, there were 18, and I think that 24, Simon said, relates to the people who were photos were taken of their skin in terms of being able to make that look at that whether they fit that criteria. So the conclusion of that is that we need some help with diagnosis, and it's really exciting to hear these developments with PCR because it would be really useful in our context to be able to use that in some of these difficult to diagnose situations. Treatment challenges, of course. So I don't commonly tell patients about my own health problems, but with scabies, because of this whakamā and stigma, I actually do often say, I've had scabies too, my whānau have had it too, and I know it's really hard to deal with, and it's really itchy and horrible. And I often do that, because especially if I see that the patient has an initial response of, oh no, it's scabies, have I done something? And I often reassure people it's nothing to do with your hygiene, it's nothing to do with how often you have a shower or anything like that. So there's sometimes some education needed and just reassuring people that it's not anything to do with hygiene, it's just skin-to-skin transmission, and it's just, and sometimes I use my own experience for that. Multiple people to be treated at once. There is on healthedge.gov.nz there's a 3-page booklet that I print that one of the pages looks like that. I gave that to the 2 patients on Wednesday, and it's got some of the details about treatment. So I usually use that along with the verbal instructions about how to treat everyone in the household, do all the washing and so on. With this, a lot of whānau costs associated with the treatment and with the scabies itself. So the costs of coming to see the doctor for an adult patient, the costs for scripts if you're an adult patient. A lot of patients are having to go to a laundromat to do all of this laundry, the time, and I know that when I've had this, had to treat it with my own household, it's just this. It takes up your entire weekend because you're having to treat the kids. They don't want to be treated. They're running away from you. They're screaming, and you've got to treat you've got to do all the washing of all the sheets and all the clothes and everything. We've talked about the effects on sleep education, work. Kids aren't allowed to go to daycare until they've been properly treated, so that's time out of education, time off work for parents, and the health costs, of course. So as GPs, we also kind of have a role as, or in primary care health professionals, we have a role in advocacy for our patients. And so thinking about kind of the root causes, we've talked about the high rates in areas of high deprivation, so thinking about advocating for living wage in the places where we work, looking at the other risk factors that this family have. There are some healthy homes initiatives such as AWHI in Counties Manukau and some other similar ones in other areas. I don't think that scabies is on the list of criteria to be able to refer someone to this Healthy Homes initiative, but the family may have other risk factors that do tick the box in terms of social risk factors or respiratory conditions. So thinking about referral to look at their housing. Clinical care, thinking about guidelines. I like the idea after hearing these presentations that we need to be thinking about diagnosing scabies in the suspected category rather than being too sure of our diagnosis. It's better for us to be over-treating this condition, even if we're not 100% sure of diagnosis, because it is so widespread, especially in the communities that we work in. And effective treatment, if we are able to use ivermectin in children safely, that would be a thing that we'd like to know. I do use ivermectin sometimes when there's been treatment failure, but that special authority is a little bit of a barrier. And that is all I have. So thank you. And any questions?